No, sir, he's not in the list.
He's not yet joined, no?
Good morning, Dr. Lad.
Yeah, good morning, Ushaben. Good morning, Jitesh.
Yes. Good morning. Good morning. I just called up Dr. Akash. He is joining in 2 minutes.
Good morning, Anil.
Sir, good morning.
Good morning. Good morning.
Hi, good morning.
Good morning, Dr. Shukla.
Good morning.
Recording in progress.
A statement was made while other
Yes, ma'am, you can start.
We can start.
Yeah. Good morning, friends. I welcome you on behalf of Indian Medical Association Mumbai branch and Indian Medical Association CGP sub-faculty Mumbai branch. Today we have got a multi-speciality seminar. We have got the experts in their field of specialization. They will update us. Now, everybody must be knowing that the MMC renewal process has already been started. Those who have not renewed their MMC credit point, kindly contact either MMC office or IMA office and they will help you. Now I will hand over the mic to our president, Dr. Jitesh Mehta. He will update us the upcoming events of IMA Mumbai branch. Over to Dr. Jitesh Mehta.
Hi, good morning, everybody. As Dr. Usha has already mentioned, we are having the MMC points to be renewed. This is a very crucial month, and so we are trying to have maximum webinars and maximum CME points to be collected for the needy, I can say. So, one important announcement I have to make is that our Indian Medical Association Mumbai branch annual conference, which was supposed to be on 2nd of Jan, had got postponed. And now we shall be having this conference on the 6th of March. So that is the first Sunday when after everything is opening up by the end of February, I think everything according to government guidelines is opening up. And so there should not be any restrictions. It is the very next, the very first Sunday after the lockdown opening will be happening on in the end of February. So we are going to get the maximum benefit before any other variant comes. We shall do with our conference, and we shall be comfortably doing the conference. So all those who require points, they can contact the IMA office. A few delegate seats will still be available. So those who want to attend the conference can come to the IMA office at the earliest and contact the office people to get the delegate ticket. So 6th of March, note down, is our conference, annual full day conference. We'll be having 2 credit points in that. We have got an array of wonderful speakers in that on that day, and I'm sure it will be a very memorable conference. So with this announcement, I hand over the mic back to Dr. Anil Awad. You can just conduct the further proceedings. Thank you. Dr. Anil is there. I think you take over.
Okay. Now we'll start our program. The first speaker is Dr. Akash Shukla. Let me first introduce the speaker. Dr. Akash Shukla is the director and consultant in the Department of Hepatology at Sir H.N. Reliance Foundation Hospital and Research Center. He has done MBBS, MD Medicine, DM Gastroenterology, followed by fellowship in hepatology and liver transplant from Barcelona, Spain, and Petersburg, USA. He has over 20 years of clinical experience, over 86 original published research papers, and is known for teaching and training gastroenterologists and hepatologists for over 15 years. His paper has won the plenary award at Asia Pacific Association for Study of Liver 2018, Best Research Paper Award at VALDIG meeting at Switzerland 2016, and national awards 4 times. He has written textbooks on jaundice and non-alcoholic fatty liver disease. He is a world-renowned expert and done pioneer work in the field of vascular liver diseases. He is the first non-European to be nominated to the steering committee of the Vascular Liver Disease Interest Group EASL Europe. He has also been a part of authorizing several international and national disease management guidelines for various liver diseases like acute liver failure, acute on chronic liver failure, nutrition in cirrhosis, hepatitis B, hepatitis C, and NAFLD, etc. He has worked extensively in the field of transplant and currently holds honorary post of Joint Group Director in charge, Rotosoto West and Maharashtra, and Joint Secretary, ZTCC Mumbai. He is also a State Advisory Committee member of Government of Maharashtra on organ donations and transplant. Today he will be speaking on what's new in the management of hepatocellular carcinoma. Welcome, sir. Over to Dr. Akash Shukla.
Good morning, everybody. At the outset, I would like to thank IMA for inviting me for this topic. And thank you for those lovely words of introduction. And it's indeed an honor and a pleasure to be presenting this talk on this lovely Sunday morning. So I'll be talking to you about the management of hepatocellular carcinoma in 2022, getting the best outcomes. I remember when I was a resident, we used to, when we got a patient of HCC with decompensated cirrhosis, we used to just say, okay, this is the end of the story. You will live for 3 to 6 months, 9 months, and just do whatever you can and just give a best supportive care. From there, we have reached a stage where we can offer a good therapy and very often a curative therapy for a majority of the patients. Even those who have got a advanced HCC, we still have treatment options. So we do not need to now give up on patients with HCC. And therefore, I would take you through what is new in the next few minutes. The first question comes, whom should we do surveillance for hepatocellular carcinoma? Why this is important? If we diagnose hepatocellular carcinoma when the patient doesn't have symptoms due to HCC, the cure rate is almost to the tune of 95%. Whereas if you pick up HCC when the patient has developed symptoms because of HCC, then the cure rate comes down to below 25%. And therefore, it is extremely important that we try to diagnose HCC when the patient is asymptomatic for the HCC. So all patients who have got cirrhosis, child A and child B, should be undergoing an ultrasound and an alpha-fetoprotein every 6 months. Same way, patients with Child-Pugh C cirrhosis who are awaiting transplantation should undergo. Those patients who have hepatitis B and have crossed the age of 40, whether they are asymptomatic carriers, whether they have active hepatitis B or cirrhosis, once they cross the age of 40, every 6 months, we should do an ultrasound of the liver and an alpha-fetoprotein. A very important thing to understand here is, please ask for a USG of the liver for these patients. What happens when we ask for a USG full abdomen? They will do the kidney, the measurement of the kidney size and the other organs, which is really not required. So rather, I would want the sonologist to spend more time on looking at all the segments of the liver. So we should ask for only USG liver or USG upper abdomen to ensure that all the segments of the liver are properly assessed. And with this, we will be able to diagnose almost 60 to 70% of the HCC very early in the course of the disease. Next, we come to how do we diagnose HCC today? Today, we diagnose HCC based on what is called as the Lyrides classification. We do not need to do liver biopsy for patients with HCC majority of the times. Classical radiology or a high alpha-fetoprotein is sufficient. So based on this Lyrides, what we look at is on a good multiple phase CT scan, not just a dual phase or a triple phase, but a multiple phase where there is an arterial phase, there is a venous phase, and there is a delayed phase. You look at the arterial enhancement of the tumor, then you look at washout, you look at the pseudocapsule, and you look at the rate of growth of the tumor or the lesion. And based upon that, you classify your patients as LR3, LR4, or LR5. LR3 are the ones who may be developing HCC in the future but are currently benign. LR4 are probable HCC and LR5 are definite HCCs. And that is why how today we classify. And this is not my own. This is basically what the EASL criteria also talk about. So they clearly say that we need to diagnose patients based on radiology. Now, where should we do a biopsy today? So biopsy today should be done if the lesion is less than 2 centimeter size and we are suspecting HCC, or we do it in patients who do not have cirrhosis of liver and have a normal alpha-fetoprotein. And third, in patients who have got vascular liver disease like Budd-Chiari syndrome. So in these three groups of patients, today we would do a liver biopsy. Remember that a normal alpha-fetoprotein does not rule out HCC. So you can have a HCC, but a normal alpha-fetoprotein. And therefore, we need to evaluate these patients once you find a lesion in the liver with a good CT scan or an MRI. Once we have seen and diagnosed HCC, then we need to stage the disease. And the staging of the disease is classified as very early, early, intermediate, advanced, and terminal stage. It is only in the terminal stage, that is the stage D, that we offer only supportive care, best supportive care. But for everybody else, we have a treatment option. So we know that for very early stage, you can do ablation or resection. For early stage, we have the options of resection, transplant, or radiofrequency ablation. For intermediate stage, we have the option of transarterial chemoembolization or radioembolization. And for stage C, we have systemic therapy. And as you can see, for a majority of the patient, if you diagnose early, the survival is more than 5 years. And for the intermediate stage, it is more than 2.5 years. And even for the advanced stage, it is more than 10 months now. Now, can we improve it further? So this is how we have been managing for the last 10 years. And yes, we can manage it further because now we move on from BCLC to Hong Kong liver cancer staging system, which looks at only 3 stages: early, intermediate, and locally advanced. And this is based on size, number of nodules in the liver, and presence or absence of an intrahepatic venous invasion. And based upon this, you classify your patients to stage 1, 2, 3, 4, 5A, and 5B. For stage 1 disease, you have the option of transplant, resection, or ablation. For stage 2, you still have the option of resection. For stage 3, you have the option of resection or TACE. For stage 4, we do systemic therapy. For 5A, we do liver transplantation. And it is only in stage 5B that we give supportive care. So the difference between this HKLC and BCLC is multiple. Here in HKLC, it is much easier to follow. For patients with very advanced liver disease but early HCC, you have offered transplantation. For intermediate stage HCC, we have actually offered resection, which was not being offered previously. And it is a more practical classification because you have combined ECOG 0 and ECOG 1 into one category. And if you follow the HKLC algorithm, for patients who have HCC beyond the early stage, the survival instead of 9 months, according to BCLC treatment, would increase to 16.6 months, according to the HKLC treatment. So you get a benefit of almost a year. If you have somebody who is BCLC-B and you reclassify them and if they become HKLC-2, then the 5-year survival increases to 52% instead of 18%. Similarly, those patients who are BCLC-C, if they get classified as HKLC-2, the 5-year survival, which would have been 0, increases to 48.6%. Why this treatment? Why this difference? Because the treatment recommendations between the two groups are different. So multifocal tumors or intrahepatic vascular invasion is not considered a contraindication for resection. Ablation is recommended for tumors up to 5 centimeter. The intrahepatic vascular invasion is not considered a contraindication for intraarterial therapies. And therefore, more aggressive treatments can be given to these patients, resulting in better outcomes. But we have to be very, very careful in patient selection in terms of the liver function reserve. When you decide treatment for HCC, you look at the three things. One, what are the tumor characteristics? What is the size? Whether it is invading, not invading? Second, you look at the patient. What is the performance status? Whether he is active or inactive, whether the patient is bedridden or still working 8 hours a day. And third, and the most important, is what is the functioning of the liver? If the patient has poor liver function, you cannot offer any of these therapies like radiofrequency ablation or TACE or TARE or EBRT. So you have to be very, very clear as to the liver function status. And that is why these patients are best managed by hepatologists. Because we have to manage the liver function while we are giving treatment for hepatocellular carcinoma. Today, we do hepatectomy beyond the BCLC indications. So even in patients who have a slightly higher MELD score, you can risk stratify your patients and go ahead with a surgical resection. Also, we have learned that we should not be doing a non-anatomical resection. The resections should always be anatomical, that is segmental resections, because that is associated with much better outcomes and lower rates of recurrence in the long run. Now you have also got the option of transarterial radioembolization, a very important technique which has come up. Previously, we used to have patients where locally advanced tumors, we were just giving palliative systemic therapies. But when we started doing TARE for these patients, we realized that their survival rate are much, much better, as you can see in these graphs, especially in intermediate stage and advanced stage HCC. So better and curative therapies are available for BCLC-A, and therefore we do not opt for TARE in BCLC-A. And very few patients with BCLC-C are actually eligible for TARE. But it is for intermediate stage HCC that TARE has made a huge difference in the outcomes. Now, if we move on to comparison between TACE and TARE, for patients with large sized tumors and those who have got a vascular thrombosis, TARE performs much better in patients with HCC with portal vein thrombosis. A very important alternative and a cheaper alternative to TARE, which costs 7 to 8 lakh rupees, is actually EBRT, external beam radiation therapy, which is as effective as TARE and 1/4 or 1/5 the cost of TARE. Unfortunately, at Reliance Foundation Hospital, we have each of these therapies, whether it is radiofrequency ablation, TACE, TARE, EBRT, resection, transplant, everything under one roof, where a multidisciplinary team looks at these patients and takes a decision as to which is the best treatment for the patient. Not only that, now we have those patients who have got a high creatinine. We cannot do contrast studies. So we can do what is called as a contrast enhanced ultrasound, which is basically something which is very safe for the kidneys. And based upon this CEUS, we can even ablate the lesions sono-guided. For those patients who require systemic therapy, where these local regional therapies are not possible, we have lenvatinib, which is very well tolerated, very little side effects, and most of the patients will tolerate it very well and gives a huge survival advantage, as you can see here in the brown line, as compared to the blue line, which is the placebo. When we compare lenvatinib with sorafenib, lenvatinib is much better tolerated with better outcomes over a period of 2 years. So even with advanced cancers, we can offer lenvatinib. So it has got better survival, better progression-free survival, and better time to progression with overall much better response rate. And like I said, the side effects are much lesser. Now, when we come to the intermediate stage HCC, there are different, basically, groups. It is not one homogeneous group. Those patients who are what we call as beyond up to 7 criteria, that is the number of tumors plus the diameter of the largest tumor, that gives a number. And that number, if it is more than 7, then these patients are not going to respond to TACE. And if you do TACE in these patients, they will decompensate, they will develop jaundice, ascites, and they will die very quickly. So we may actually do more harm to these patients than benefit by doing TACE for these patients. And therefore, we need to identify these 3 subgroups. Those who are beyond the up to 7 criteria, we need to start systemic therapy first, downstage the disease, and then offer a curative TACE to these patients. Whereas those who have less than 3 nodules, we can offer resection even in the presence of vascular thrombosis. For those who are intermediate in the intermediate stage, TACE is probably a good option, but even in these patients, TACE should be preceded with a systemic therapy like lenvatinib to downgrade the disease and make the patient more responsive to transarterial chemoembolization. For assessment of the liver function, we no longer use the Child-Pugh score, which we used to use previously, but we have moved to something called as the LB score now, which is very simple. Just look at the albumin, bilirubin, and it is much more objective, and there are no little confounding factors. And based upon this, today you decide which therapy the patient will tolerate. So which are the patients where you will not do a transarterial chemoembolization? Those patients who are not going to respond to TACE. Who are these? Those who have a confluent multinodular type, infiltrative type HCC, if there's an extranodular growth, poorly differentiated HCC, and if they have multiple nodules in the liver, or if there are sarcomatous changes following the previous TACE. Patients who are beyond the up to 7 criteria, and those patients who have a borderline liver function, and after doing TACE, their liver function is likely to deteriorate, that is LB grade 2B and beyond. So these patients, we should not be doing TACE. So today, the newer strategy is if you have intermediate stage tumor with low tumor burden, you offer locoregional therapy, and if there is TACE refractoriness, you offer systemic therapy. This is what we have been doing previously. But now, if there is a high tumor burden, you offer systemic therapy first, downstage the disease, and then do locoregional therapy in selected patients to offer a curative therapy. So we can now think of a cure even in intermediate stage therapy, intermediate stage HCC, and achieve excellent outcomes. Another chemo which is now available to us is a combination of atezolizumab plus bevacizumab, and it is superior to sorafenib in terms of efficacy as well as in terms of safety. There is no head-to-head trial with lenvatinib, but it is now first-line therapy along with lenvatinib for most of the patients. It improves survival, and it also improves survival without any disease progression. So it is as superior to sorafenib in this aspect. Not only is improved survival, but it also improves quality of life. The only problem is the cost. It is expensive, but it is an option. So even BCLC has now come up with a modification. This was the upper half is the original BCLC, and the lower half is the newer BCLC, where they have now also defined what should be done in case patients do not respond to the first line chemo, second line chemo, and third line chemo. So all these drugs now are easily available to us. So not only TACE, TARE, ablation, resection, transplant, but systemic therapy like atezo, bevaci, lenvatinib, cabozantinib, regorafenib, sorafenib, all these therapies are available to us, and it is now the time to have MDTs decide the right therapy for the patients in the MDT and then take a call, because the key determinant of outcomes of these therapies is actually the underlying liver function. So this is a further detail of how we manage HCCs in 2022. This is published as recently as November 2021. Now, what do we do if the patient has a progression despite giving therapy? So if the patient was child pug A and the progression is due to new extrahepatic lesion or a new vascular invasion, you classify them as BCLC PC2. If the patient has an increase in the nodule size or there's a new intrahepatic lesion, then you classify them based on what was the baseline BCLC, BCLC-B or BCLC-C. And based upon the BCLC-CP-B, CPC1 or CPC2, you decide which will be the best therapy in the future. Now, these are all the drugs which are going to come in the near future and will become available to us in the next 3 to 4 years. And each of these drugs will have a specific indication. They will not be competing with each other for all the patients. And this will be based on the molecular characteristics and the molecular signatures of the tumor. And each one of them will have an indication based on the tumor characteristics and the functioning of the liver disease and the cause of the liver cirrhosis. So the therapy now is moving from broad general therapies to patient-centric, target-oriented, individualized therapy for HCC. So what are the take-home messages? HKLC staging appears to be superior to conventional BCLC, and now you have the modified BCLC, which is incorporated response to therapy. We need to be more aggressive for resection. The intermediate stage of HCC is heterogeneous. TACE should not be offered to all patients, but whenever we are doing TACE, it should be done with a curative intent, with or without preceding lenvatinib therapy. For patients who are beyond the up to 7 criteria, a systemic therapy should be done first and then TACE or ablation with a curative intent. Lenvatinib is safer than sorafenib and has similar efficacy, and atezolizumab is now the first line. But the key thing is that it is a multidisciplinary team which has to decide what is the right treatment with hepatologist at the center, because it is a liver function which will decide which therapy the patient is going to tolerate. So HKLC or modified BCLC is now going to be the preferred modality to take these decisions. Thank you very much, and I'll be happy to take any questions.
Sir, what are the risk factors in cellular carcinoma?
So for HCC, the most important risk factor is presence of cirrhosis. From etiology point of view, it is NASH today, non-alcoholic steatohepatitis or the fatty liver, which is the #1 cause of HCC in my practice. The second cause is hepatitis B, and third cause is hepatitis C patients who have already been treated and cured but have advanced fibrosis. So those patients should continue to remain on surveillance. And patients with alcoholic cirrhosis who have stopped alcohol, they continue to be at risk for development of HCC.
Any question from the panel? Sir, all the patients with liver cellular cancer are curable?
So today, majority of the patients who present to us with very early, and intermediate stage HCC can be offered a curative therapy. Only for those patients who are presenting to us with the advanced HCC, we may not be able to offer a cure to all. But even in those patients, we can improve their quality of life and we can improve their survival.
They have to take the lifelong medicine, sir?
Yes. For those patients who have advanced disease, they have to take lifelong. But those who have early disease, intermediate stage disease, there is no need to take lifelong. There are modalities of therapy, like I discussed, which are of finite nature.
Yeah. So how and when do you decide that this patient requires the liver transplant or will be benefited from the liver transplant?
So for liver transplant, we look at the Milan criteria or the UCSF criteria. So patients who have small tumors in the early stage, not the very early stage, in the early stage HCC, we offer liver transplant because liver transplant is curative in these patients. Those patients who cannot undergo a liver transplant or immediately undergo a liver transplant, we can bridge them using multiple therapies that are available to us like TACE or radiofrequency ablation.
So at what level of alpha fetoprotein would you suspect HCC?
I think that's an excellent question. So when we are putting our patients on surveillance, an alpha fetoprotein level of above 20 is when you'll start suspecting HCC. However, you have to remember that majority of the patients who develop HCC in India do not have an elevated alpha fetoprotein. So you can have a large HCC also, but a perfectly normal alpha fetoprotein. So do not rely only on alpha fetoprotein during surveillance. Any new lesion which you start seeing on ultrasound, we must suspect it to have HCC.
That was a wonderful talk, Dr. Akash. Thank you very much.
So every time you are teaching us and we are learning something new things every time. Thank you so much for giving wonderful this lecture.
Thank you very much. And now we have a full team with me, Dr. Monka, Dr. Sevanti, Limaye. Everybody has joined recently in Reliance. So I'm sure we'll be able to take very good care of your patients.
Now Reliance Hepatology is shining.
Yeah.
Thank you. Thank you very much.
Thank you so much, sir. Now we'll move to the next speaker. The next speaker is Dr. Sevanti Limaye. And to introduce the speaker, I request our IMA CGP member, Dr. Dakshini Kashyap, to introduce the ma'am. Over to Dr. Dakshini Kashyap.
Good morning, friends. Dr. Sevanti Limaye is Director Medical Oncology, Director Precision Oncology, and Director Clinical and Translational Oncology Research at Sir H.N. Reliance Hospital and Research Center, Mumbai. Dr. Limaye received her medical degree with honors from Jawaharlal Nehru Medical College, Bhagalpur, and did her residency in internal medicine from New York University, and did her fellowship in hematology and medical oncology from Albert Einstein University, New York. Dr. Limaye also did a master's in patient-oriented research, cancer genomics, and biostatistics from Mailman School of Public Health, Columbia University. She's been involved in research with leaders at Memorial Sloan Kettering Cancer Center, Dana-Farber Cancer Institute, Columbia University Medical Center, and National Cancer Institute, USA. She serves on Tata Memorial Hospital Ethics Board. She has led several national and international trials and has been a part of data safety monitoring boards. She was awarded with the John Flynn Young Investigator Award for Excellence in Clinical Research and the Rose and Jack Horowitz Award for Excellence in Patient Care and Medical Oncology Research Excellence Award, ASCO 2008, for Excellence in Clinical Research. She was nominated to serve as the National Chair of the Sub-Protocol Arm B of the landmark NCI MATCH trial. Today, she will speak on personalized therapy in cancer.
Thank you for the kind introduction. I would really warm greetings to all the members of IMA. I have, as you know, I'm coming from Kokilaben Hospital, and so I'm known to the Juhu IMA, and it's a great pleasure that I'm coming on to the first talk. And right after Dr. Akash's wonderful talk. So yes, it's a multi-D team that is coming together at Reliance Foundation Hospital, and it was already there. We are just going to add our bits. And in effort to bring in oncology to the next level, I have been brought in for looking at personalizing therapy in oncology. And we heard a wonderful lecture, and in an extension to that talk is mine, wherein the effort is to actually try and identify biomarkers to enhance response to treatment to a different level. So we all understand that 2/3 of cancers, and I'm just going to present a story which will help us understand what I'm going to talk about. So when we have cancer treatments, the focus is on early diagnosis. The focus is also on trying to treat better. When we have a patient who is already diagnosed, the onus and responsibility to treat better is on the oncology team. That is where the concept of personalizing therapy for the patient comes in. It's not a new concept. It's actually, I think, a cliche where we try to talk about how we could strategize the treatment recommendation for the patient and make it more precise so that the patient can benefit from the therapy in a more organized way and hopefully enhance survival for the patient and also decrease morbidity and mortality. So we all know cancer is an ailment that is very much in our face. And whenever I talk about this slide, I really shiver, because the truth is that 1 in 2 men and 1 in 3 women will be touched by cancer in their lifetime. So cancer is very much an epidemic. And when we talk about one we have just gone through, this also has really caught stream. And it was about time we waged a war in all walks of cancer treatment, in early diagnosis, in treating early stage cancer better, and in also trying to save lives, prolong lives, and make life worth living when we diagnose cancers in a late stage. So a harsh fact is cancer does not discriminate. And in that, since cancer generalizes and each one of us in some way or the other, whether it's us, ourselves, or our family or our friends are going to be touched by the disease, how can we make the disease treatment more personalized, more focused, more tumor-driven, specific to that person, specific to that tumor? The concept is, again, an old one. It's not a new concept. When we talk about giving blood transfusions, we are actually focusing on blood transfusions that are cross-matched. We are giving to the specific blood group. When we are giving chemotherapy, again, we are giving chemotherapy to a particular body surface area. So we are measuring the height and weight, and we are calculating the body surface area and then organizing the therapy according to the body surface area. When cancer care is being practiced, most of us are following guidelines. And guidelines could be organ-specific, guidelines could be place-specific, guidelines could be driven by what we follow. So one of the things I realized when I relocated to India, until then I was following US guidelines. So 6-7 years ago when I came in here, we were following US guidelines, UK guidelines, and then there would be an occasional person coming from Australia and saying, this is the Australian guideline. And then the next person coming from Germany and saying that this is the German guideline. So as much as guidelines are important, I think it is also important to take into heed that particular patient and figure out the biomarkers that are specific to that patient and organizing, strategizing therapy along those biomarkers. That's what my onus is. This has actually revolutionized cancer care, I feel, and really brought to the forefront N of 1 concept. What is essentially N of 1 concept? N of 1 concept is each patient is unique in its own, and can we strategize treatment wherein we put together the guidelines as well as understand the patient's disease and tumor better and organize treatment around that concept. So when we look at non-small cell lung cancer, as you see in this slide, all these patients are non-small cell lung cancer. What is the EGFR positive non-small cell lung cancer? It may just be 25% of a particular type of non-small cell lung cancer. And KRAS G12V mutation plus MET amplification could be that one person and requiring that one therapy. So very critical to understand which signature the patient is having and strategize treatment based on that one patient, one tumor profile, and what options exist for that patient. Why is that important? That is important mainly because we are in a time where 75% of our patients are still being diagnosed at a higher stage. It's a race against time. And when you are in a race against time, you really need to make best use of that time. We heard about HCC just now. And I think HCC is one of the tumors where we have luxury of time where patients could come in at an early stage. Vis-a-vis, when we look at lung cancer, 3/4 of the patient are still being diagnosed at a higher stage. You really have to up the game, better your job for the treatment for lung cancer. Many people come in and ask me, what's the prognosis? And all we have is the type of lung cancer. And my answer at that juncture, in that minute, is I will hold back the prognosis. Why? Because I have to do some testing. If I gave the prognosis at that minute, I would actually giving an umbrella prognosis and which would not really do justice to that patient. So how do I get to understand that patient's biology? 2009, when I was finishing up my fellowship, lung cancer was a death sentence. No longer is that the case. The idea is to try and understand the signature of lung cancer, what is the driving pathway, and treat the disease better. In that, we have to try and understand what is really driving that cancer. Cancer formation is a multi-step process. And when there are multiple mutations, genetic changes, alterations that happen as the carcinogenesis happens, is there a way to unravel that, test and figure out which gene may be responsible for driving that disease? I say this all the time to my patients. If the phenotype is of a non-smoker Asian female, that's the kind that may have non-smoking driven cancer. That patient will have a pathway. That pathway needs to be picked up and targeted. And that's the jackpot. That's the lottery. That's the treatment that will get the patient the best survival and the best quality of life. So it's very critical to understand the genomic variations in a tumor. It may be contained in the DNA, it may be the RNA, it may be beyond DNA, RNA, which is the protein, and it may be beyond the protein, which is the metabolism of the protein. So today, the field of personalization of therapy is actually something that starts with identifying the patient, figuring out the right center for the patient, figuring out the right treatment for the patient, going beyond that, picking up their tumor and understanding their tumor signature from the DNA, RNA, protein, and metabolism perspective. The field is ever evolving. What we really need to understand is that the process has actually, it's not a new process. The process has been there from the early 1990s. And here we are today, still trying to unravel the mystery of cancer. The Human Genome Project shed light on a lot of the inherent codes that were contained within the DNA of the body, of the cells. But as we go by and we come to several decades beyond the study of the Human Genome Project, we are now in application of the genomic information. But how many of us really understand the application clearly? We are still falling short of proper application. Many times I see the tests having been done and sitting in the patient's kitty and really not being interpreted or implemented to enhancement of their survival and to their benefit. That's where I feel we really need to come together with the understanding and seek the right kind of care. This is not all esoteric. This is not all hugely expensive. Many of the drugs are already available in the regular armamentarium. It's just the application of the drug at the right time for the right patient to get the best benefit for the patient. So when you look at the survival of patients where biomarker-driven therapy has been given, there are so many genomic alterations that have emerged. The naysayers will say the application rate for genomic analysis. So if you did a genomic testing and you wanted to give a targeted therapy according to the biomarker, the rates are variable. Many centers will say only 12% application, 18% application. But the rates, when you put it all comprehensively, when you bring all these results together, then the rates are actually up to 50%. 50% of these patients will be able to benefit from personalizing therapy, from understanding their cancer biology better, and an effort can be made to turn the biology to the advantage for the patient and also survival and quality of life. I always keep quality of life front and center for these patients. The road has been long, but the road is definitely leading us towards more and more personalization. If you ask me, there is actually no other way to treat cancer. We have to treat as per the tumor signature. There is no other way than to try and recognize how we could personalize treatment and design it for that specific tumor, for that specific patient. And how do we understand these? We have heard of routine RT-PCR. In the current times, everybody is doing a PCR. And if you were at our hospital, multiple times in the week. So there are many tests that have happened in this arena. But one of the tests that has emerged and is used as a very routine testing process for oncology patients is something called comprehensive genomic profiling. Something that we are also looking to bring in at Reliance Foundation Hospital. We'll have our own lab where we'll be performing comprehensive genomic profiling. For now, we are still sending it out. One of the gold standards of genomic profiling is Foundation Medicine. And it's an international testing platform, but we have many emerging labs now in India wherein we are able to perform the testing to unravel the mystery of a particular tumor type in the DNA, in the RNA, in the protein by doing immunohistochemistry, on the cell surface by doing immunocytochemistry. And also, I'm a big believer in chemosensitivity analysis, wherein we try to figure out which particular tumor type, which is heavily pretreated, may respond to a particular chemotherapy better, or what are the chemotherapy choice options for that patient who has gone through multiple lines of therapy. Many of the patients are actually presenting with tests that have been performed already. Interpretation of those tests and whether some additional tests are required are also critical. Yesterday itself, I saw a patient, a gentleman from Gujarat who had never smoked and had developed lung cancer. That is itself a phenotype, a message that this particular person may actually have EGFR mutation or ALK rearrangement or a driver pathway that can be targeted with a pill. But the patient had already gone through testing and had not been found to have a pathway. That doesn't actually answer the question. It tells you that an additional level of testing is required. The test that was done is not comprehensive enough. You have to go and find the next level of testing for this patient. Why is that so? That is just because you're not being a detective enough. You're not getting after the cancer. This is a story of a non-smoker. And so some genomic alteration has to be driving their cancer. That's the genomic alteration that you have to really figure out and target for the best benefit of the patient. Precision medicine as a concept is integral to cancer care today. One of the major leads in this was from President Obama, wherein huge funding was put into precision oncology research. NCI Match was such an umbrella trial, and I actually wrote one of the arms of the NCI Match trial. The concept is based on recognizing the biomarker, doing the test of a tumor, different kinds of tumors, irrespective of which particular cancer it is coming from, figuring out the genomic signature, and designing therapy for that patient based on their genomic signature. If it is of one particular cancer type, that could be an umbrella trial. So if you look at colorectal cancer, the battle trial had different genomic signatures. All colorectals, battle trial, were given different kinds of drugs. In lung map study, early stage lung cancer was actually given different kinds of maintenance as per the pathway that was discovered for these patients. Similarly, if you talk about basket trials, these are trials where you have all kinds of tumors that are brought in, tested, found to have a pathway, and treated with those kind of drugs. That has led to discovery in lung cancer of so many genomic signatures. So earlier, lung cancer was only small cell lung cancer, non-small cell lung cancer. And non-small cell lung cancer was squamous, large cell adenocarcinoma. Now you have a whole host of different kinds of lung cancer. And if you can see my cursor, all of these mostly are targetable. So you have pathways, and when people ask me, like I said, a prognosis without knowing the pathway, I refrain from giving them an answer. Because today, for me, lung cancer is majorly subclassified into two different kinds. Lung cancer that can be treated with targeted therapy, and lung cancer that cannot be treated with targeted therapy. And then the question comes in whether they can be treated with immunotherapy. So to understand different variations in lung cancer and longitudinally follow these variations. So a lot of these patients go on targeted therapy. They will respond, and then eventually they will progress. When they progress, you really need to understand what is driving their pathway resistance. Pathway resistance may require longitudinal study, may require repeat biopsy, or a liquid biopsy, a blood biopsy. And with that, you're able to then define what is the resistance pathway of that particular patient and design your treatment accordingly. So I have a patient living right near where I live, and the patient actually was EGFR mutated, which means that he can be treated with a pill. So patient responded to the pill-based therapy for 2 years. Then he came to me and he had cough. In that cough, there was blood-tinged sputum. Rescan the patient, and there are some areas waking up, so his disease is no longer responding to that particular EGFR inhibitor. This is a patient where you would do another biopsy, you would do a repeat blood test to try and figure out what is the resistant pathway, and that's what is outlined. And when you understand the resistant pathway, you may not actually need to jump to the next line of chemotherapy. You can add another drug, and with that second pill, this patient is once again responding to the pill-based treatment, which he takes at home with minimum side effects, doing very well, tolerating it very well. The cough is gone, there's response on PET scan, and you know that you've addressed the resistance with the help of the second drug that has come in. The new kid on the block in terms of biomarker identification is immunotherapy. Now, the biggest challenge with immunotherapy is that we don't understand which are the patients who will respond to immunotherapy. And that's where identifying biomarkers of response from immunotherapy are very critical. Why is that so? Because of what just Dr. Akash said about his patient with SCC. So advanced SCC, what's the frontline therapy? Frontline therapy is atezolizumab and bevacizumab. And when you go to atezolizumab and bevacizumab, it's 4 lakhs a dose. So there are patient assistance programs where the monetary involvement of the patient comes down. It's still 2.5 per therapy. That's a lot of money, and whatever literature there exists in India, 1% of Indian population is going to be able to afford that kind of treatment. So if you're going into that kind of heavy investment, Do we know, is there a guarantee? Patients ask me all the time. And that's where immune biomarkers have to be realized, developed, and understood better. Some of the ones are already available. One of the immune biomarkers is actually PDL1, which is programmed cell death ligand 1 receptor, which is tested on the tumor cell. The other one is tumor mutation burden. The third one is microsatellite instability, and also tumor infiltrating lymphocytes. Now, the concept of tumor and immune biomarkers is actually ever evolving. We haven't come to a clear understanding still, despite all the tests. There are tests being developed where you're piecing all of this together and trying to come to a better understanding by understanding the TMB, the MSI, the new antigen presentation, and the PDL1. But still, I feel that the tumor microenvironment is a very unresolved subject where a lot of research is still required. I have participated in some of this work since 2012. Still, we don't have answers for those trials and application. So for now, I say this all the time, the ultimate test of whether an immunotherapy drug is going to work or not in a patient is actually by giving it to the patient. So the harsh truth remains that till now, we don't have a perfect biomarker, but we do have certain emerging biomarkers. One of them is really relatively new is tumor mutation burden. And to understand the tumor mutation burden ranges and where the immunotherapy can be applied is one of the work that we do in Precision Clinic, and really piecing it all together to bring down more impact to therapy for lung, breast, GI malignancies, and GU malignancies is the onus and is the force of today's approach in our Precision Clinic. Similar to lung clinic, but not so far, is still the breast approach and precision in breast cancer. And we know earlier it was mainly ER, PR, and HER2/neu, but as of now and further, this is a dated slide 2016, we have, 6 years hence, we have more markers and more understanding of the EGFR2, of the EGFRs, of the FGFR amplification, of the PIK3CA. We already have a drug against PIK3CA in India, and of course the hormonal signaling, and 10% of breast cancer that happens in hereditary conditions where you have DNA damage repair pathways, BRCA, and gynecological cancers, again, where signatures of immune therapy, targeted therapy are all coming through. Some of the patients can even be candidates for hormone therapy. So understanding the biomarker signature, it becomes more and more critical. Some of this will actually not present in the tumor tissue testing. In that case, we go ahead and study the blood. That is mainly because there is a concept of intratumoral heterogeneity. The tumor signature may not be present when you biopsy that part of the tumor. And that's where you will need to take a blood biopsy, because certain tumors shed in blood. And when they shed in blood, it's called ctDNA, circulating tumor DNA, or circulating tumor cell. And when the tumors shed in blood, you can actually do a blood biopsy and get some of the information, signature information regarding the tumor from the blood test. And the blood test can be done at the doorstep of the patient, and you can figure out what may be the signature for that tumor based on the blood biopsy. A lot of the tumors actually are big shedders. They can be found to a large extent in the blood, and the characteristic tumor profiling can be done from blood. But then there are other tumors, like you see the small bars here, gliomas, thyroid cancers, that are not shedders, where in picking up the information from blood may be quite difficult. Also, you need to know that there is a huge concept of understanding the tumor signature through blood. And that concept actually tells you that we fall 25% short of application of signatures when we do the blood test versus when we do the tissue test. So in doubt, you have to actually do the tissue test. When we go into the application of the blood test, if we are falling short of biomarkers that are definitive and signature to the behavior of that cancer, in that case, we may want to go and do a repeat biopsy to understand the tumor signature better and really design treatment to that effect. One of the trials that demonstrated this method was a trial called Shiva trial. Shiva trial was a multi-center trial run in Europe, actually in France. And when you look at the application, they looked at several markers that were contributing to cancer progression, and they strategized treatment based on these markers. This is an age-old trial. This actually resulted in 2015. Now we are 7 years hence, and we are still struggling with this concept worldwide, but more so in India. It's high time that we understood this and really went ahead with the application of this kind of strategy in our clinics. One of the things that I actually do, and I think I'm running short of time, so I'm going to scoot over to my patients. That we do here in our center is we do the profiling, we look at the evaluable markers, we figure out which are the druggable markers, what are the targets, we identify the targets, and then we treat the patients according to the targets. There are multiple limitations to this approach, and as I mentioned initially, when we are applying target-driven, biomarker-driven treatment, there are patients who may not have the markers. And when you don't have the markers, how do you go about treating such patients? So there is an 80-year-old who's a non-smoker and comes in with cough and giddiness and found to have abnormal CT brain. And this patient is studied further and tested to be positive, was negative for EGFR, ALK, ROS, and PD-L1 TPS score was 0, which means most of the initial biomarkers are all negative. And that's when you do a comprehensive profiling. And here this patient is found to have a TMB that is high, very high, 29 mutations per megabase pair, which tells me that this patient may be able to respond to immunotherapy. I just mentioned 3 major biomarkers for response to immunotherapy. One is TMB. This patient has a high TMB and would respond to immunotherapy. What happens to this patient? This patient is also found to have a BRAF, a classic BRAF mutation. But the BRAF inhibitors are targeted pills, 2 pills that the patient needs to take. More tougher to tolerate, this patient chooses to go on to immunotherapy. And you look at the amazing results from immunotherapy that are seen here. When you have just 4 months of treatment, almost complete resolution of disease with the immunotherapy, and including resolution in the liver. When you look at this PET scan, started out like this, and here complete resolution to the disease and maintained resolution in all areas of presentation, including multiple sites in the lung and liver. So the patient continued to be in remission. In lung cancer situation where there were no classic biomarkers, that's where you test in a broader way to come to a conclusion. This is a salivary gland patient with a painful mass, locally advanced disease, and then finally stage 4, and found to have initial surgery, radiation, chemotherapy, all of that, and lung lesions. And then metastatic salivary ductal. I'm not going to go into all those details, but HER2 amplification is seen. What is HER2 amplification? HER2 amplification is classically described in breast cancer, but this patient had HER2 amplification. And so the patient was treated classically as per breast cancer because the patient had that genomic signature, but this is salivary gland cancer, which is now metastatic to all sites. And patient was given dual HER2 inhibition and chemotherapy, low dose, and complete response to treatment till date, an amazing presentation. Another patient wherein 62-year-old gentleman has suprapubic and perineal pain with mucoid discharge. And you can see the mass is right here in pelvis. It's right here, and undergoes surgery, intraoperative sigmoidoscopy, and intraoperative biopsy. And if you see here, a colostomy is required, adenocarcinoma, likely colon cancer. As per diagnosis, patient was started on FOLFIRINOX, does not respond to FOLFIRINOX. You can see the tumor actually grows. We do a foundation 1 analysis, and in this we have KRAS mutation, BRAF, wild type, but high tumor mutation burden. Again, a signature for application of immunotherapy in a colorectal situation where actually there is no real role of immunotherapy unless the patient is microsatellite unstable. And this patient, you can see after 2 FOLFIRINOX, which is classic regimen, actually disease progresses. And when pembrolizumab is applied, the patient has complete response. Similarly, this is a 4th case of gallbladder cancer, metastatic, treated with FOLFIRI, and started on off-label use of nivolumab. And then you see here severe progression. So you have to understand, when you do genomic profiling, there is a patient who actually is on immunotherapy, and the patient has progression on immunotherapy. You try to understand why the patient may have progressed. And there is a marker for progression which is known to contribute to progression from immunotherapy, that is called MDM2 amplification. And had this patient had this genomic profiling done before coming to me, we would have not put this patient on immunotherapy. So not everybody is going to benefit from expensive drugs. We have to know where the application is needed and where it is not, and how you could benefit and where it could actually be detrimental. Similarly, this is an anaplastic thyroid cancer, wherein liquid biopsy gave us a signature amplification, EGFR mutation and BRAF amplification in the patient, wherein erlotinib, which is not a drug utilized in thyroid cancer at all, it's a lung cancer drug, because EGFR mutations are classic lung cancer signature. And so this patient was, as an anaplastic thyroid patient, was put on erlotinib, and you can see that the patient had excellent response to this pill. And so the idea is to really try and understand the biomarkers that are driving the cancer and organize your treatment according to that biomarker. This is an HCC patient, wherein heavily pretreated sorafenib, ramucirumab, immunotherapy with nivolumab, and was found to have MET amplification. Now, for MET amplification, today in India, we have many drugs that are oral pills and can be utilized. And in this patient was treated on a trial with a MET inhibitor, but in India, you have crizotinib as a traditional MET inhibitor, and then you have capmatinib, which is a drug that has been launched for MET inhibition, and it's easily available, readily available in India. So the point I'm trying to make is actually, if you have the understanding to really get out there and understand the patient's molecular signature better, the treatment can be organized to that tumor type, and survival and quality of life both can be preserved in a better way. The onus is on us today to identify the need for such an application and getting our patients to the right center to do the testing, to understand their tumor biology and strategize their treatment according to their tumor type. It has become more and more critical and integral to cancer care, because, as I say, time is tight. So you have to really apply the best foot forward at the first meeting with the doctor. Thank you for this opportunity. I hope I was able to convey my concept to the IMA team. And once again, this is a huge opportunity for a wonderful introduction to this IMA family, and greetings to all on the Sunday morning. Thank you.
So it was a very wonderful session, madam.
Thank you.
There is one more question. Is there any protocol for emphatically management? And do you carry out any research to see whether this emphatically patients treated, managed?
So we are actually putting together a huge research vision at Reliance Foundation. One of the reasons why I have been brought in here to is actually to put up that wing. As we set up the center, we are actually going to not just bring in the research opportunities that are available through multiple multinational companies. We are actually looking at setting up our own research initiatives, and integral to the center will be research initiative in precision space. So the precision oncology program is actually going to have a clinical fellowship track and a research fellowship track. And we are going to study all our patients, and they are going to be tracked. And so we are going to have annotated data for all our patients right from the beginning. So to answer your question, yes, ma'am, we are going to have multiple research initiatives. I'm also a thought leader for many international research initiatives in biomarker discovery field, and that is actually going to merge with my current effort. So we will have on one side an effort to reach out to the masses in tier 2, tier 3 cities. On the other side, a lot of this research will be integrated with the international level research that is happening worldwide.
Doctor, I have one question.
Yes, ma'am.
Is there any biomarker for oral cancers, squamous cell carcinoma?
Wonderful question. Wonderful question. So actually, this is one of very big challenges that I face as a treating oncologist in my yesteryears. If you look me up, for a short time, I was a head and neck medical oncologist as well as an early drug development person. So head and neck is very close to my heart. Now fast forward coming to India, you have all oral cavities, big oral cavity cancers, wherein they are biomarker deficient. They're actually, when you sequence them, a lot of these cancers they'll have P53 mutation, but they won't have anything targetable. So where do you go from there? You know, if there are no targets, how do you proceed? So that's where actually there are two efforts that I'm already a part of in the past, and one effort that I'm putting through immediately to immediate effect. I believe in chemosensitivity profiling. So those who can't benefit from biomarker driven treatment, what would that include? So 12% to 18% of head and neck cancers will have a marker, which you can target with a pill. So one will have to sequence and figure out if there is an HRAS, if there is a PIK3CA, but these markers actually don't have such a magical effect as you see in lung cancer or other malignancies. Head and neck does not respond the same way. So even if you put the pathway directed treatment and you put the pill on, the patient will not have a magic. So then you have to figure out what will bring the magic, what will shrink the cancer, how can you cut it out? In that scenario, understanding immune biomarker, one, and two, whatever is left, then if you have 80% of the patients not having a biomarker, how can you still benefit them? That's where I feel drug sensitivity comes in as a very critical addition to your treatment armamentarium. In today's time, if we don't have technology that can take us further, can we do drug sensitivity to give the right chemotherapy or right chemotherapy and repurpose targeted therapy to these patients, or immunotherapy combinations? That's where I've been involved in drug sensitivity trials. One of the leading companies is Datar Genomics. They do drug sensitivity with a test called tumor exacta analysis, live tumor tissue, ship it to the lab, take it there, put it in a petri dish, do reverse engineering by testing 300 to 500 drug combinations on the tumor tissue in the petri dish, bring that information back to the patient and try and treat the patient in a better way to get higher responses. So a lot of effort being made in that area, and that biomarker identification is actually beyond the classic biomarker that we talk about, where we are talking about the EGFRs, the KRAS, the RETs, the METs, and immune microenvironment. You are getting into the age-old, but still in today's time, trying to take it, enhance it to the next level by understanding which one is more sensitive. So hopefully
what is the success rate of targeted therapy, and how long the patient live on targeted therapy?
Again, a great question. So I have survivors on targeted therapy for a decade. So there are some patients who will develop pathways of resistance in 2 years. And if you look at median, most of these drugs around 2 to 3 years will start developing pathways of resistance. So 2 answers. One, we have multiple generations of these targeted therapy drugs, first generation, second generation, third generation, fourth generation coming through. So if the patient progresses on one line, you could still add the second line. If you could still add the third line. So there are more mature drugs coming through that could still be applied to enhance therapy. So targeted therapy control period can increase. One answer. Second answer is pathway of resistance. So I believe in doing longitudinal genomic analysis. If this pathway is blocked, agar ye pathway nahi kaam kar raha hai, so how can we add another drug to make that pathway work? Or what happened? What happened? Did this tumor transform? Does this tumor from adenocarcinoma become squamous? Did this become small cell? तो सेकेंड बायोप्सी बहुत लोग नहीं करते हैं, तो मेरा कहना है आप सेकेंड बायोप्सी करो, पहचानो कि क्या हो रहा है, ट्यूमर कैसे ट्रांसफॉर्म कर रहा है, and if it is transforming, you understand and treat better. One of my EGFR positive patients is actually now on immunotherapy. Immunotherapy is contraindicated in EGFR inhibition, but I biopsied her. I figured out that this is transformed into squamous. She's going to respond to immunotherapy. Now she has completed 2 years of immunotherapy. So 2 साल targeted therapy पे, 2 साल immunotherapy पे, still living, no evidence of disease. Sorry. Too much information.
I think you are going to change the way totally the cancers are being treated.
Yeah.
And more research, and then less and less you know, and you feel that the road is still longer and longer ahead.
Thank you, sir. The idea is to make the disease chronic, and it's such a pleasure meeting you all. And I feel I'm in the same room.
You are going
Thank you very much.
Yes.
Definitely.
Join the committee.
Yes, sir. Yes, sir. Thank you.
Thank you very much.
Thank you so much for having me.
Thank
Yes,
you,
thank
ma'am.
you.
Thank you.
Wonderful.
Dr. Anil Awad, are you there? Dr. Awad seems to be. Yeah. So I request Dr. Anil Awad to.
Jitesh, I think I'll do it after this lecture.
Okay, we'll do. Okay. We're going to announce something which is related to IMA, and that will be after the lecture of Dr. Okay.
Thank you so much, ma'am. Now we'll move to the next speaker. The next speaker is Dr. Shrikant Atloori, sorry. Now to introduce the speaker, I request Assistant Secretary, IMA CG Mumbai Sub-Faculty, Dr. Kajal Ahuja, to introduce the speaker. Over to Dr. Kajal Ahuja.
Dr. Shrikant Atloori is a consultant uro-oncologist and robotic surgeon within the division of oncology at Sir H.N. Ryan's Hospital and Research, Mumbai. He is an expert in all types of urological cancer with special expertise in robotic surgery. He has done MBBS, MS General Surgery, and MCH Urology. He did fellowship in urology oncology and fellowship in laparoscopic urology, robotic assisted urology from University of Miami Hospital, Miami, USA. At present, he holds 5 years of robust, dedicated, exclusive training in urological malignancies from premier most institutes in India and USA. In India, he spent 2 years in esteemed Tata Memorial Hospital, Mumbai. He has worked with stalwarts like Dr. Deepen Parekh, Dr. Chad Rich, and Dr. Sanoj Punen in a renowned University of Miami Hospital, Florida, USA, for 3 years. He is a member of many national and international organizations like American Urology Association and Urological Society of India, etc. He has a strong academic background and has been part of various research projects since his undergraduate days. He has several publications in international peer-reviewed journals and presentations in international meetings. Today, he will be speaking on overview of urological cancers. Over to Dr. Shrikant Atloori.
Thank you so much. Thank you, Kajal ma'am, for such a kind introduction. And at the behest, I would like to thank IMA for giving me the opportunity to talk in front of such a wonderful crowd. So let me first share my screen. So after a wonderful talk by Dr. Sevanti on personalized therapy in cancer and by Dr. Akash Shukla and of course in liver cancer, I'm going to carry forward my talk about cancers, but I'll restrict to my specialty, that is urological malignancies. And I'm going to give a broad overview and try to cover all the urological malignancies, starting from from basic information to the most recent advances, what we are seeing in urological malignancies. I'm going to talk a little bit about screening tests, which is most relevant in prostate cancer. I'm going to talk about how to catch the disease early so that we are offering them cure, like by not ignoring the symptoms which are usually ignored. And I'll tell you why I'm saying like that in the relevant talk afterwards. And then what are the recent advances, starting from diagnostics to the therapeutics in urological malignancies. So as we know, the global burden of not only urologic cancer, but all the cancers has been increasing. And there is a nice paper here which says that there is a 2.5-fold increase in the incidence of urologic cancers since 1990s. So there is definitely a rise of cancers. So what we can do it. So we know that the early diagnosis, if we catch them at an early stage, there's a high chance that we can offer them cure. So that is our goal today, so that we can pick them early by doing screening, or whenever they have a symptomatic presentations, we try to catch those symptoms early, which is related to the cancers, and offer them cure. So this is what I was talking. So we do screening where we, like especially in prostate cancers, where we do a PSA and try to catch the prostate cancer earlier, or whenever they have symptoms, we try to catch them at an early stage by picking up those symptoms which are relevant to the urological cancers. So what is uro-oncology? Basically, it involves all the cancers related to the organs which are related to the urinary system. So we have kidneys, adrenals, ureter, bladder, urethra, penis, testes, and prostate. So I'll start with the big threes in the urological cancers, which are the kidney cancers, urothelial cancers, and prostate cancers, which are the most common type of all the urological cancers. And then I'll speak a little bit about the rest of the cancers. So coming to the kidney cancer. So the most common malignancy is renal cell carcinoma. 90% of those is a renal cell carcinoma. Of those, the histologic subtype which is most commonly seen is clear cell carcinoma, and the papillary and chromophobe are the next two in the line. Nowadays, more than 50% of the cancers have been diagnosed incidentally. That is, they are getting ultrasound done or a CT scan done for an abdominal pain, and then they found out that it is having a renal mass or there is a cancer in the kidney based on the imaging. The classic triad, which that was used earlier for diagnosing kidney cancer, flank pain or hematuria, that is blood in urine, or abdominal mass, is rare nowadays because we are more and more picking these incidental tumors at an early stage. But we need to keep in mind that even nowadays in some places like remote places of India, still we see a lot of patients with these three symptoms. And when we find the patient with such a symptom, it's usually an advanced disease. And then we have the symptoms of bone pain and persistent cough, which is usually indicative of a metastatic disease. So what we look for in an examination, we look for a mass, abdominal mass, we look for cervical lymph nodes. Usually they are enlarged in metastatic settings. Or we need to look also for if their patient is having any non-reducing varicocele or bilateral pedal edema, which is usually indicative that the patient is having a renal mass, and with that they are having a renal vein thrombosis or IVC thrombosis, which is causing back pressure changes, giving rise to these signs. So what do we do the next in the imaging? What is the most common imaging which is used? That is the CT abdomen pelvis with a renal protocol. So what is this renal protocol? They take a plain film first, plain CT, and then they inject a contrast, and then they take the films at the corticomedullary phase and nephrogenic phase. So the CT, which is diagnostic of a renal cell cancer, is that on giving IV contrast, if the enhancement is more than 15 to 20 harmful units, it is usually renal cell carcinoma unless proven otherwise. So, and what all we also look on the CT scan. The most important thing is we look for the opposite kidney also, the function and morphology of the contralateral kidney. And then we look for the primary tumor extension of the mass, that it will give us a T stage, venous involvement, is there any renal vein thrombus or IVC thrombus, are there any nodes, and the condition of adrenal glands and other solid organs like liver and all. Suppose if the patient is having a raised creatinine or is allergic to the iodinated contrast, then we do MRI abdomen with and without contrast. So these are the conditions where we do it. When the patient is allergic to contrast, or the patient is pregnant and she cannot take iodinated contrast and radiation from the CT, then we do the MRI in them. And also MRI is useful when on CT we can, IVC thrombus is poorly defined. MRI is the imaging of the choice. But we need to understand that MRI also is contraindicated with the contrast if the GFR is less than 30 ml per minute, because it has been shown that if the contrast is given when the GFR is less than 30, it leads to nephrogenic systemic fibrosis, meaning that patient will have all over the body, the fibrosis process starts in, and then he have fibrotic nodules in the skin, lungs, and tissues and everywhere. So when the GFR is less than 30, you can either do MRI abdomen plane or a CT abdomen plane, because we don't have any choice other than that. For staging, we usually do a chest X-ray. If the renal mass is small, like less than 4 centimeter, chest X-ray suffices. Or if we have an advanced renal cell carcinoma, usually CT chest is advised. Biopsy of the renal mass, we should do a biopsy only when it will change the management. Suppose we have a renal mass and it is more on the imaging, it is a definitive that this looks like to be a more likely to be a renal cell carcinoma, then we should directly go do the staging investigation and start the treatment. The biopsy is only indicated when, suppose if he has a renal mass and a metastatic disease, then we have to do a biopsy just to diagnose it's a renal cell carcinoma. And then the medical oncologist, as Dr. Sevanti Limaye said, then they will take the treatment further with the personalized therapy. Also, when you're suspecting, okay, this renal mass doesn't look like to be a classical RCC on the imaging, or it looks like to be a lymphoma or a tuberculosis when the patient is having symptoms of TB, then also we can do a biopsy just to make sure that the mass is not a cancer and may be related to lymphoma or tuberculosis. So that's the role of the biopsy. Coming to the cysts in the kidney, usually we see a lot of ultrasound pictures saying that there is a cyst in the kidney, and then they report it as a simple cyst or complex cyst. This is the Bosniak classification which is given. The Bosniak classification is mainly based on a CT. So my advice would be, whenever you see a simple cyst on an ultrasound, if it's a clear water-filled cyst, then we don't need to evaluate further. But if the radiologist say that he sees some septa or some complex cyst, then definitely CT abdomen plus pelvis should be done with a renal contrast, and so that we can more have characterized these complex cysts. Because according to this classification, the Bosniak category 1 and 2 are usually benign. 3 and 4 complex cysts are usually malignant, and we need to treat them. 2F comes in between these two, and then we need to personalize depending upon the treatment, depending upon the imaging findings for the 2F. So these are the images for the cysts. The above image is a clear simple cyst. Below, definitely there is an enhancing septa and a nodule in between, which is a more common likely that it is seen in RCCs. So coming to the treatment, initially radical nephrectomy was the treatment of choice, but now we have moved on and tried to conserve the nephrons. So partial nephrectomy is coming in a big way. So whenever possible, if the kidney, we are able to save the kidney, at least 20% of the kidney, then partial nephrectomy is the treatment of choice. So that all depends upon the staging also. Like for T1 tumors, which are T1A and T1B, T1A is less than 4 centimeter, T1B is less than 7. Partial nephrectomy is the treatment recommended. But if the tumor is advanced, like if the mass is large, more than 7 centimeter, where we cannot save 20% of the kidney, or there are renal vein thrombosis, IVC thrombus, or regional lymph nodes, then the radical nephrectomy is the treatment of choice. There are ablation which can be used like RFA or cryotherapy, but we usually do not recommend when a patient is fit for surgery. It's usually reserved for patients who are not fit for surgery. They can undergo ablation because the local recurrence rates of ablation after ablation is high, 15 to 30% as compared to 2.5 to 3% for the surgery. And then of course we have immunotherapy and targeted therapy for metastatic disease. Next common thing in the big three is the urothelial cancers. So typically the urothelium cancers are divided into upper tract and lower tract. So upper tract includes renal pelvis as well as ureter, and the lower tract includes bladder and prostatic urethra. So all these, starting from renal pelvis up to the prostatic urethra, is lined by urothelium. So these are called as urothelial cancers. And most commonly they present with the symptom of hematuria, that is blood in urine. Gross visible blood in urine is a symptom which is usually presenting symptom of the urothelial cancers. Sometimes they present with microscopic hematuria, that is they undergo an executive health checkup, or they have some urinary symptoms and then they undergo urine routine, and then they found that they have a microscopic hematuria which is usually defined as more than 3 or more than equal to 3 RBCs per high power field. So whenever you have a symptom of this hematuria, we should add additional symptoms. Is there any associated clots? What is the shape of clot? Because if it's an amorphous shape, it usually comes from the bladder. If it is a vermiform shape, it's usually coming from the kidneys or ureters. And whether is there any pain? Painless hematuria is more of a kind of an indicative of a bladder cancer. Painful hematuria like pain while passing urine is more kind of a infective or inflammatory or stone disease. The patient can have a flank pain also. So flank pain from the clots, which are leading to a clot colic, or there may be a tumor in the ureter, which is obstructing the ureter and causing flank pain. And then we need to do the etiology. Most common etiology is the smoking for the urothelial cancer. So we should ask for the history of smoking. Sometimes if the patient eats a lot of beetroot, then also we find that the urine is red colored and the patient will have hematuria. But then on urine routine microscopy, we can differentiate whether there is a real hematuria or not. Drugs like cyclophosphamide also cause cystitis and which can lead to hematuria. So whenever we have this hematuria, as I was telling, this is the most ominous sign of urothelial cancer, and we should not ignore any kind of hematuria at all. Recently, a few days ago, I saw a patient who said that he had seen blood in urine starting from like 2021 in March, and then he kind of ignored because he said it's COVID, and then he thought it's related to infection. He took antibiotic on himself, and then after a few months again he had a blood in urine, but he could not go to a doctor. He did not visit the doctor because of the COVID, and now he presented to me with a metastatic CA bladder. So nobody knows whether if when he had come in 2021, like in March, like a year ago, maybe he may not be a metastatic at that time, and we could have been able to cure his cancer by treating the cancer at that time if he was not metastatic. So hematuria, any kind, should not be ignored, and he should be worked up further. And then we differentiate these hematurias, whether it's coming from the glomerular or non-glomerular, like basically whether it's due to nephrology or urological or whatever we call as surgical cancers. So the most common causes of glomerulonephritis, thin membrane disease, nephrotic syndrome, and all those kind of related to the nephrology people. And then the non-glomerular causes, we have kidney, ureter, bladder, other. And most common is the urothelial cancers. Then we can have stone disease, we can have infection, we can have inflammation, we can have polyps, the patient can have undergone radiation to the organ like colon or prostate, and then he has radiation cystitis. There are so many causes, but the most important is that we need to rule out cancer. So to differentiate between a glomerular and non-glomerular, urine routine microscopy is the best test. So what is the diagnostic? If there is a proteinuria, then usually it's a glomerular that is coming from the nephrology causes. And also when the RBC morphology is dysmorphic or there are RBC casts, it's due to the glomerular causes. In non-glomerular, like surgical causes or urological causes, there will be no proteinuria and the RBC morphology will be normal and there will be no RBC casts. So once we have a patient with hematuria and we say that we attribute it to, suppose it's coming due to the urology related problems, then what should be the recommendations given? So every patient should undergo a CT urogram. Even if it is a glomerular clot, still we should do these three basic tests which I will be telling. Of those, first is CT urogram, which will give us idea about the urothelial tract. Second is we should always do a urine cytology, so that picks up the exfoliated high-grade malignant cells which are present in the urine. And the third is always patients should undergo a cystoscopy. Even though if you find so suppose if you are done a CT and if you find a stone and then you attribute it to the stone disease causing the hematuria, still the patient should undergo cystoscopy, because you may never know that he may be having a concurrent bladder cancer which is not picked up on the imaging, that is only picked up on cystoscopy. So any hematuria, you should always do a CT urogram with a contrast, urine cytology, and then cystoscopy. So then the treatment options basically depends upon upper tract or lower tract. For the upper tract, usually it is a nephrouretrectomy or uretrectomy like segmental resection or distal uretrectomy if the cancer is localized. And for the bladder, it's radical cystectomy with diversion, which is a treatment of choice, standard treatment. Coming to prostate cancer, we all know PSA is a prostate-specific antigen, which is a glycoprotein secreted by prostatic cells. And its function is like it acts like a protease to enhance the sperm motility. But we need to understand that it is prostate-specific, as the name suggests, but not cancer-specific. So regarding this screening test, so what are the ideal requirements of the screening? The screening test should reduce cancer-related mortality, morbidity, and reduce the financial burden from symptomatic disease. This is the ideal requirements of screening tests. So when the PSA was available in early 1980s and all, so if we see a graph from here, the incidence of prostate cancer increased at the when the PSA was introduced, and then kind of decreased again and has been stabilized over the last years. But the mortality has kind of remained the same still, because prostate cancer is a slow growing cancer. But we need to understand that the incidence of metastatic disease of prostate cancer has reduced drastically since the introduction of PSA, because more and more cancers are being diagnosed at early stage. What are the harms of screening tests of this PSA? The main harms was it resulted in overdiagnosis of indolent cancers, and also biopsy and treatment-related morbidity and mortality, and this all added to the healthcare expenditure. So because of this overdiagnosis and overtreatment, United Services Preventive Services Task Force, USPSTF, in 2012 recommended against PSA-based screening. They said do not do PSA-based screening. But in this 2017, there was a nice paper published. We say that because in these 5 years, because the PSA was not used as a screening, this resulted in higher rates of detection of advanced disease, like metastatic prostate cancer was detected at a higher rate. So then in 2018, again, the USPSTF updated its statement, and it said that you should do a PSA screening, but it should be an opportunistic screening. That is, whenever patient comes to you, you should always inform him about the risk and harms of the PSA screening. And there is a survival benefit if we do a PSA screening and detect the prostate cancer, regarding from the PSA study. So what are the recommendations from US, that is the NCCN recommendations? They usually recommend to start a PSA-based screening starting at the age of 45 till 75. And if it is less than 1, then you screen every 2 to 4 yearly. And if it's between 1 to 3, screening interval is little early, between 1 to 2 years. And if it is more than 3, you should evaluate for biopsy. And if you are high risk, what are the definitions of high risk? African ancestry, which we don't see, they see it. That's why they have written an African ancestry. But if the patient is having a family history of prostate cancer or any germline mutations, like Dr. Sevanti told, like BRCA2 mutations, if they have been detected. So BRCA2 mutation usually cause breast cancers or ovarian cancers, but those members, like their sons or their brothers are at higher risk of developing prostate cancer also. So if these mutations are detected, then we should do the PSA screening starting at the age of 40, like 4 to 5 years earlier than those. So when to stop? So suppose if we do the age of patient is more than 60 and still the PSA is less than 1, then there is no role of screening afterwards. More than 75 years of age or life expectancy is less than 10. EAU kind of comes in the same category, but it recommends starting from the 50 years of age rather than 45 years of age. So what should we do when they have the elevated PSAs? Usually it's recommended digital rectal examination by a urologist. And the main risk factors are age, increasing age, race and ethnicity, not Asian population. It's not related to that. It's mainly related to the African people who are increased risk of prostate cancer and a positive family history. So what we should do whenever we find a PSA, if it's more than 3, we should always repeat PSA in 2 weeks, because there may be a subclinical infection or inflammation that has caused transient jump in the PSA, which will subside if we repeat it in 2 weeks. But in repeating also in 2 weeks, if the PSA is elevated, is more than 3, then we should evaluate. And also we should ask for any lower urinary tract symptoms he's having, because benign prostatic enlargement also causes rise in PSA. And of course, a digital rectal examination by a urologist or a uro-oncologist where he feels for the prostate whether there is a nodule present or not. So if the patient is having persistent elevated PSA and DRE is suspicious, definitely he requires a biopsy. If the DRE is negative or DRE is, even if it is suspicious, then we should do multiparametric MRI of the prostate. And if multiparametric MRI is negative, we do biomarkers. I'll talk about this later now. So coming back to multiparametric MRI, it involves various parameters. That's why it's called as multiparametric MRI of the prostate. So it involves the T2, which is the anatomical sequencing. And then we have these functional components like diffusion weighted imaging and apparent diffusion coefficient and dynamic contrast enhancement. So all these 3 features are taken into account to read a prostate MRI. And then they give a score, which is called as a PIRAD score, which is called a prostate imaging and reporting and data system. And it gives a score from 1 to 5. So 1 and 2 are usually benign. 4 and 5, high likelihood that they will have the cancer. 3 comes in an intermediate risk, intermediate category. What are the additional uses of MRI? It also tells about how big the prostate is. What is the anatomy of the prostate? Is there any median lobe which is projecting into the bladder? It can give an idea about the T stage of that lesion, whether the lesion is coming out of the prostate, and or whether there are lymph nodes also, which gives us the idea about end stage. But MRI in its own also has limitations. There's a wide inter-observer variability. Not everyone is comfortable reading the multiparametric MRI of the prostate. So the radiologist has to undergo a dedicated training for that. And also not every urologist is able to read it. So a uro-oncologist who had a dedicated training is good at reading those MRI of the prostate. And the second thing is that 30% of the time, though the patient may have a clinically significant cancer, MRI may be negative. So what we do in those cases? Then we use these biomarkers. There are various biomarkers which are like, some are PSA derivatives like PSA density, PSA velocity, or free PSA. Or there are these blood-based, urine and tissue-based markers. These blood, urine and tissue-based markers are still not available in India. So we use these clinical factors and these PSA derivatives. When the PSA is elevated, but we are done, MRI is negative, then we take account into the DRE, how is the digital rectal examination, and these PSA derivatives, which will give us an idea whether patient needs biopsy or not. So this is regarding whether patient needs biopsy or not when he has elevated PSA. And suppose if we decide to do a biopsy, now the recommended is to do an MRI fusion biopsies, where if suppose on the MRI there is a lesion seen there, and then we do a transrectal ultrasound, then we use these 2 images like MRI and ultrasound images and overlap them and try to hit that lesion so that we don't miss that lesion, and additionally sample the rest of the prostate. This can be done cognitively when a radiologist or a urologist who is very confident in MRI and ultrasound images, he can do it by himself and he can target that lesion. or it can be done software based. There are multiple softwares available which will do it for us. They will take the images from both the MRI and ultrasound and do the overlapping and help in guiding the lesion. Or we can do in bore MRI fusion biopsies, where the biopsy is done in the MRI suite. But usually it's not very comfortable for the patient. Patient should be in the GA, and the MRI suite is not a suitable location for to do the biopsy also. So usually it's cognitive or software. Suppose if the MRI is negative and still we go ahead with the biopsy, so we do a standard truss biopsy, which should include at least 12 cores, 6 from each side, 6 from right, 6 from left. This is the standard recommendation. So whenever you see a biopsy report which is not including a 12-core biopsy, then usually it's an underrepresentation of the biopsy. There are various routes which biopsy can be done: transrectal, where we do go through the rectum, or transperineal, where we go through the perineum. So usually the gear is shifting from transrectal to transperineal. When I was there in USA, initially we were doing all transrectal, but in those 3 years, by the end of 3 years, we shifted to transperineal, because in the transperineal almost there is no risk of any infection because we don't reach the rectum. There is a better sampling of the prostate, because in the transrectal approach, it's very difficult to sample anterior prostate. But the only disadvantage is still it's a new technique, so it's not very familiar. So to adapt this new technique, it will take some time, but eventually transperineal biopsy will become the standard of care. So when we detect the prostate cancer, there we have a full bucket of treatment options available, starting from active surveillance to radical prostatectomy to radiation to focal therapy, which we don't have still in India, to androgen deprivation therapy and newer drugs for metastatic prostate cancer. Coming to a testicular cancer, usually it's seen in young age, present with a testicular mass. As we all know, we do an ultrasound of testis and scrotum. We do tumor markers, which include alpha fetoprotein, LDH and beta HCG, and stage them with a CT chest, abdomen, pelvis. And the treatment is high inguinal orchidectomy, where inguinal incision should be done. No, we don't do orchidectomy through the scrotum. So because if you violate the field, then there is always a chance of increasing the risk of recurrence in the inguinal region, because we violate the field and we violate the lymphatics of the scrotum. So high inguinal orchidectomy is the treatment of choice. And then depending upon the stage, we do a retroperitoneal lymph node dissection or give radiation or just observe the retroperitoneal nodes. Then talking about penile cancer, unfortunately, we see a lot of penile cancers here, maybe related to poor hygiene, phimosis, no circumcision, chronic balanitis, prostatitis, which has been ignored. And usually it's some older people, more than 50 years of age, and they present with the growth over penis. Some people also have inguinal lymph nodes, but sometimes they may not have a palpable inguinal lymph nodes. So we can do a CT abdomen or pelvis or MRI pelvis if the clinical assessment is not obvious. And then definitely we need to do a biopsy of the penile growth. And then the treatment depends upon like partial penectomy or a radical penectomy with iloinguinal lymph node dissection, depending upon the stage of the cancer. Urethral cancer, very rare, usually present with the discharge, bloody urethral discharge or blood in urine, or there may be extraurethral mass, or this mass may cause retention of urine or cause pain or fistulas or dyspareunia. Very rare in our country. So, but still these are the symptoms. If anyone presents with this symptom, then we have to do MRI of the pelvis, which will give us an idea about the T stage of the cancer. And then depending upon the stage, either he will need exenteration or urethrectomy or lymph node dissection or maybe chemotherapy if it is metastatic. Adrenal masses, commonly seen as incidentalomas. So whenever you see an adrenal mass, the first thing we should do is we should see whether it is hormonally active or not. So we should send the serum cortisol, we should send plasma phe metanephrines or normetanephrines, which are usually indicative of FeO, and plasma aldosterone and renin activity. So these are the 3 tests which we should send whenever we see an adrenal mass. And then the imaging will be either a CT abdomen pelvis or MR, both are good. And depending upon whether it's, if it is hormonally active, definitely it requires treatment. And if the size is more and suspicious for cancer, then also it requires surgery. Coming to the role of PET in uro-oncology, we know now the PET is available so much. So more and more PET has been utilized, but I'll try to just say a few things about what evidence says. In renal cell carcinoma, PET scan is usually not recommended. This I am talking about FDG PET. In urothelial cancers, you can do FDG PET to stage the cancers. Prostate cancer, we do a PET CT, but that is PSMA PET, which is very specific for prostate cancer. We can do an initial staging as well as a recurrent prostate cancer. Testicular cancers, no need of doing PET. Penile cancers, you can do the PET. So penile cancers and urothelial cancer, you can use FDG PET to use for the staging, while in prostate cancer, you can use PSMA PET. So after all this talk, suppose we find the malignancies and we decide to do surgeries, as I told you. So the surgical approach is starting from open surgery, age-old, traditional in big incisions we used, then we shifted to laparoscopy, where small multiple incisions were used with a minimally invasive approach concept that resulted in less incision, less pain, faster recovery, less scarring, cosmetically better, faster recovery to the normal life. But then came this robot, which is an advancement of like minimally invasive approach, like advancement in the laparoscopy, where there were distinct disadvantages of laparoscopy, which has been overtaken by this robot. So what is robotic surgery? So the robot consists of a patient console, surgeon console, and the robotic cart. So in the robotic cart, we have these instruments. We have the ports where we insert the ports and the robot is attached to those ports, and surgeon sits at the console, and then he operates, guides the movement. He does a movement which are reflected in the robot inside the body. So that's how the robotic surgery is done. So what are the advantages of robotic surgery? So all the disadvantages of lap has been covered here. Like it provides a stable platform with operator control camera. You don't need an assistant to show the camera. So you self-control the camera. There is an enhanced 3D vision, and it's very ergonomically advantage for the surgeon. Surgeon can do it by sitting. So if a long-standing cases, so surgeon doesn't feel the fatigue. There is an elimination of fulcrum effect and tremors. There are no tremors absolutely. There's an ability to scale the motions. Scale the motion means you can, like if you can control the movement of instrument inside while you are doing it outside in the console. Suppose if you do a 1 centimeter movement, and if you outside, and if you like outside you do a 3 centimeter movement, and you want a 1 centimeter movement inside, that also you can do. And of course, there's a 7 degrees of freedom of movement. There is an endorest movement. You can go with these long instruments deep in the pelvis, and you can rotate any ways how you want, which is not there in laparoscopy. So speaking regarding myself a little bit, after completing urology in 2016, I dedicated myself to train in uro-oncology, as Dr. Kajal has told, where I trained 2 years in Tata and then 3 years in University of Miami. In these 3 years in in Tata, I got a good experience in open as well as laparoscopy, and I was assisting for robot also, but not much cases were done there because Tata has only one robot and every specialty used to use robot. So we urology used to get only once. But in University of Miami, in these 3 years, I have done more than, like I've been part of more than 750 robotic procedures, all uro-oncological surgeries. And in the last year of my fellowship, I independently performed 200 surgeries, more than 200 robotic surgeries from skin to skin. And also with that, I had an opportunity to perform more than 250 biopsies, which included both MRI fusion and standard truss biopsies. So I do all the uro-oncological surgeries, starting from open laparoscopy to robotic approach, from nephrectomies to nephrouretectomies, cystectomies, everything. And of course, also the urological procedures. So thank you for your patient listening, and I'm ready to take any questions.
Thank you, Doctor. It was a wonderful lecture. Now there is a questions from the audience.
Yes.
For a Bosniak 2F cyst, how long would you recommend screening and at what interval?
So Bosniak 2F cyst, I'll screen them every yearly. So you can alternate with your ultrasound or a CT. And if it's kind of stable for first 2 to 3 years, then we can increase the intervals, like then go to 2 years or 3 years. And then after 3 years, that after 5 to 6 years, if it's still stable, then we can just let go.
Okay. And when do we start the BCG?
When do we start?
BCG?
Yes. So bladder cancer is typically, whenever it's localized, is divided into whether it's muscle invasive or non-muscle invasive. So in non-muscle invasive bladder cancers, we again re-stratify them into low, intermediate, and high risk. So typically BCG is given in high risk non-muscle invasive bladder cancers, which include any T1 lesions, like the lesion is the going into lamina propria, or any high grade lesions, or any lesion which is showing lymphovascular invasion or prostatic urethral involvement. So all these lesions are come into a bucket of high risk category. There we should give BCG. And what we follow is induction and maintenance protocol. So induction, we give BCG every weekly for 6 weeks. So this is the induction. And then maintenance, we give at 3 months, 6 months, and 12 months, and thereafter every 6 months till 36 months. So usually recommended is to give 3 years.
Okay. What are the treatment of different grades of urothelial carcinoma, and what will be the cost?
This is regarding bladder cancer or what?
Urothelia. There is a question from the audience.
No, so urothelial, as I told, you need to divide whether it's coming from the upper tract or lower tract.
Okay.
So if it's an upper tract, it's surgery. Like you do a radical nephrectomy with uretrectomy, or you do a just segmental resection of the ureter. If it is a lower tract, then as I told, it's mainly the bladder cancer, and then we need to divide it into between muscle invasive or non-muscle invasive. Muscle invasive, definitely cystectomy. For non-muscle invasive, we re-stratify again. Low risk, we don't do anything. We just surveil the patients. We just give 1 dose of mitomycin after the TURBT is done. And then we just do a cystoscopies, starting like follow-up cystoscopy at 3 months and 9 months, and then every year till 5 years. In high risk, we do BCG, and then we do regular cystoscopies every 3 months for first 2 years. And then after that for 6 months till 5 years, and then we can go on yearly if there is no recurrence. And intermediate comes in between low and high risk. You can either give a BCG that we give only for 1 year, or you can give intravacycle chemotherapy like mitomycin or gemcitabine for 1 year. And then for intermediate, we usually do a follow-up at 3 months, and then every 6 monthly for first 5 years.
Okay. What is the life expectancy of this non-invasive and invasive cancer?
So yeah, so non-invasive are pretty much curable disease, but we need to only understand that there is, it all depends again upon risk stratification. If it is a low risk, definitely he has a very good life expectancy, like 90 to 95%. But if it is a high risk, there is a 50 to 70% chance of recurrence and 30 to 50% chance of progression. Recurrence will maybe of the same grade or same stage, and progression meaning in the sense the non-muscle invasive becomes muscle invasive. So that's why high risk is a very notorious tumors, and we need to be very careful, especially in these high risk categories.
Sir, I will ask one question. If the cancer of the ureter, if there is a stricture, there is no metastasis, the patient age is 67. What will be the treatment?
So if it is a 67-year-old and you have a ureteral cancer, so we need, whenever there is a ureteral cancer, we need to see whether it's upper, middle, or lower ureter.
If it is lower.
So if
lower,
it is a
lower end.
If it is a lower ureter, then we need to see what is the grade of the cancer on the biopsy. If it is a low grade, then we can just remove that distal segment, which is called distal uretrectomy, and then we can reimplant the rest of the ureter to the bladder. But if it is a high grade, to give him a best oncological cure, ideal recommendation is to do a nephrouretrectomy, and along with that, you remove the bladder curve.
Okay. Thank you so much, Dr. Shrikant. It was a very nice session.
No, I would like to thank you, IMA, again, all the IMA families also. Thank you so much, and I'll be soon be member and be a family part.
Thank you so much.
Thank you.
Yeah. Now we'll move to the next speaker. Before that, our president-elect, Dr. Anil Awad, will announce some announcement of the IMA branch, and he will also introduce our own Dr. Surendra Shingnapukar for the next speaker. This is the last speaker. So over to Dr. Anil Awad.
Yeah. Good afternoon, everyone. I request Dr. Atloori to close down his presentation. Yeah, thank you, sir.
Sorry for that.
Yeah, no, it's okay. Friends, this is just an announcement regarding the vasectomy center, which we have already started. We had a very newly renovated family welfare center where we have started vasectomy center. We have highly trained surgeons who will perform the surgery, and the persons who get vasectomy done will be given a handsome remuneration. The very purpose of telling you about the center is that the center was ready for quite a long time, and because of the Omicron epidemic, it was not functional. But we have started the function. This is the state-of-the-art vasectomy center with all new things, and this is how we consult in the OPD or center. These are the pamphlets which are available for all the doctors who are interested. I mean, they are in a very large number. You can just collect the pamphlets from the IMA Mumbai branch. And one more thing is that all the people who get vasectomy done and the person who introduces the patient will be given a very good handsome remuneration. The amount you will come to know when you visit the IMA office. And another announcement is that we have one more post of part-time medical officer with us. So again, for that, you can contact IMA office. So do refer the patients to vasectomy center and get a handsome remuneration. So this was about the vasectomy center. I'll just introduce our next speaker, that is Dr. Surendra Shingnapukar. Dr. Shingnapukar is a family member of IMA. He is the head of Department of Lab Medicine, Raheja Hospital, Mahim. After completing his MBBS and MD in pathology, he did MBA in health service. He is an ex-lecturer in pathology, TN Medical College and BYL Nair Hospital. He has worked in the area of laboratory quality management to get NABL accreditation at Raheja Fortis Hospital under his able guidance. He has special interest in hematopathology, clinical pathology, and immunology. He has worked as medical superintendent at Raheja Fortis Hospital and is part of Hospital Ethics Committee. He was visiting lecturer at PV Polytechnic, SNDT University for 10 years and was also SNDT University examiner for DMLT curriculum. He has presented papers at state and national level and has various publications to his credit. He is a very active member of IMA Mumbai branch and currently is the honorary treasurer of IMA Mumbai branch. I request our own Dr. Surendra Shingnapukar to proceed with his presentation.
Hello. Can you hear me?
Yes.
Can you see my presentation?
Presentation नाही दिसत आहे डॉक्टर शिंगणापूरकर.
शेअर केलं मी, शेअर करतो.
I have stopped sharing, so you can share. Yes.
Can you see it now?
Yes, your screen is visible.
Not visible to me.
You're seeing the Google Chrome screen. Go to the desktop now. You must have stored it there. Yes, right. Yes, seen.
Yeah, one minute. Yeah, shall I start? Can you
Yes, yes,
see
yes.
my screen?
Yes.
Yeah. Yeah, thank you, Dr. Awad, for lovely introduction. Good afternoon to all. I'm thankful to IMA President Dr. Jitesh Mehta sir and managing committee members for having me to address this one of the most commonly asked and practical topic. Today we had so many topics related with oncology, but this topic is very practical and it will be a revision for all of us, especially for family physicians who ask this test very routinely in their day-to-day practice. Now, before going to liver function, it is necessary to know that liver is one of the largest solid organ in our body. Also, it has large reserve capacity and it's capable of regeneration. So this is so important when we want to know the test available for liver pathology. Now, when we talk about test, there is no single test which can assess liver's total functional capacity. So we need to do battery of tests during evaluation and management of patient with liver disease. Now, where this test help? Now, basically, this test help to differentiate the type of liver disease, assess severity and progression of liver disease, and follow the response to the treatment. So we have to do this test repeatedly once patient is diagnosed with liver disease to know the response to the treatment. Now, along with these tests, we need sometimes to do imaging studies like ultrasonography, CT scan, MRI during the diagnosis and management of liver disease. Now, points to remember as far as liver function test. Now, these tests can be normal even with serious liver diseases. Results may be abnormal in conditions other than primary, which are not primarily hepatic, like heart failure, sepsis. These liver function parameters can be abnormal. And this test very rarely suggests a specific diagnosis, but it categorizes different liver diseases, like whether it's a pre-hepatic, hepatic, or post-hepatic. Now, also the enzymes, what we do in liver function test, they don't measure liver function, but they detect if there is any hepatocellular damage or there is cholestasis. So this is very important. The individual tests do not highlight any liver function, but it detects if there is a damage or there is a interference with the bile flow. Now, liver has variety of functions in our body, and they can be categorized into different groups. The most important function of liver is synthetic function, or it is involved in production of plasma proteins like albumin, globulin, and almost all coagulation factors are produced except factor 8. All coagulation, fibrinogen, prothrombin, and all, they are produced in liver. Then there are a variety of transport proteins like transferrin, which transports iron, is also produced by liver. Also, liver is involved in metabolism, lipid metabolism, where cholesterol, triglyceride, fatty acids, and phospholipids and lipoprotein are produced in liver. Liver has a major role in glucose homeostasis. So whenever there is excess of glucose, it is stored by liver in a glycogen form. And also when there is no glucose is available, glucose can be produced from other sources like fats and lipids by the process of gluconeogenesis. So glucose has a very important role in glucose homeostasis. Then other function of glucose is liver is detoxification and excretion function. Now ammonia, which is produced at the end of protein metabolism, this ammonia is toxic to the body, but liver detoxifies ammonia to urea, and then ultimately the urea is excreted in urine. Also bilirubin, which is produced by the breakdown of RBCs, which enters into the liver, gets conjugated and then ultimately excreted in bile. Similarly, there is excretion of cholesterol into the bile. Then variety of drugs, what we prescribe to the patients, most of these drugs are detoxified by metabolized by liver and excreted into the bile and then ultimately to the urine. Then there is a storage function for liver. Most of the fat soluble vitamins like if vitamin A, D, E, and K are stored in liver. Similarly, vitamin B12 is also stored in the liver. Then with the help of bile salts, it helps in lipid digestion. So these are the variety of liver functions, starting with synthesis, detoxification, storage, and production of bile salts in the digestion of lipids. Now, patients with severe hepatic dysfunctions are expected to have low plasma urea, low plasma cholesterol, low glucose, low serum albumin, and high ammonia level. Now, which are the various biochemical parameters generally studied in liver function test? We all know these. Very commonly, we prescribe them, but we need to know how to interpret and how to categorize based on these parameters into different liver disorders. Commonly asked is bilirubin, SGPT, alanine aminotransferase, aspartate aminotransferase or AST, alkaline phosphatase, GGTP, gamma glutamyl transpeptidase, and serum proteins, albumin and globulin ratio. Now, what is the importance of these biochemical parameters in liver disease? Now, these parameters help us in differentiating if there is acute hepatocellular damage. Now, especially AST and ALT are present within the hepatocytes, and they measure the integrity of hepatocytes. So whenever there is damage to the hepatocytes, these enzymes are liberated into the blood, and we see rise in ALT and AST in hepatocellular damage. Also, they are very sensitive index of hepatocellular damage. So these are the first enzymes which are rise when there is a damage to the hepatocytes. Then other thing what these parameters indicate is if there is any biliary tract obstruction, like cholestasis. Now, whenever there is blockage to the bile flow, the bilirubin concentration rises. The alkaline phosphatase enzyme, which is present in biliary canalicular cells, there is increased synthesis and release of this alkaline phosphatase into the blood. Then gamma glutamyl transpeptidase, which is also richly produced by biliary lining cells, and 5-nucleotides, which has similar importance as alkaline phosphatase. Then in chronic liver disease, as we said that liver has a storage function, also it has a synthetic function. So most of the plasma proteins, especially albumin, are produced by liver. So once patient goes into chronic stage, the synthesis by liver of these various proteins decreases, and serum albumin is also, we can see the decrease in serum albumin when in chronic liver disease. Of course, it's a crude method of measuring liver capacity, synthetic capacity, because there are other factors which can also decrease albumin concentration, like especially kidney disease can reduce albumin concentration in blood. Now, this based on functions of liver, the substances which are produced by liver, albumin, cholinesterase, and coagulation factors, these tests are based on the synthetic function of liver. Cholinesterase also, which is involved in neurotransmission at nerve level by acting on acetylcholine, is also produced by liver. And as I said before, almost all coagulation factors, fibrinogen, prothrombin, except factor 8, is produced in the liver cells by the liver. Then there are certain tests which are based on the release of these substances once there is damage to the hepatocytes. Whenever there is damage to the hepatocytes, AST, SGOT, and SGPT, we can see rise in these two enzymes. And also there are endogenous compounds there is increased synthesis by liver canalicular membrane, bile duct epithelium, endothelium of central and periportal veins. These enzymes there is increased secretion of these enzymes by canalicular cells of epithelium. Alkaline phosphatase, gamma GT, and 5-nucleotide. Then there are certain tests which are based on the clearance mechanism, clearance function of liver. Bilirubin, which comes from the blood breakdown of RBCs, and then it gets conjugated within the liver cells and ultimately excreted into the. So if there is any problem with the conjugation as well as excretion of this bilirubin into the duodenum, we get a rise of bilirubin. Then there are bile acids and ammonia, which is produced by at the end of protein metabolism, also cleared by the liver into the bile, into the urine after converting it into urea. So these are the three tests which help us to identify clearance function by the liver. Now there are variety of conditions where we can see hyperbilirubinemia. Hemolysis is the most commonest, most important to know, because there is rise of unconjugated bilirubin in hemolysis. Once there is damage to the RBC, there is breakdown of hemoglobin into heme and globin, the heme molecule which further broken down to the unconjugated bilirubin, and which causes overload to the liver conjugating system, causing hyperbilirubinemia. But in hemolysis, we have increased unconjugated hyperbilirubinemia. Then hyperbilirubinemia can be due to if there is a problem with the conjugation system of the liver, especially the enzymes which are involved in conjugation. If they are lacking, the unconjugated bilirubin will rise. And finally, hyperbilirubinemia can be due to the obstruction to the biliary system. When there's conjugated hyperbilirubinemia is commonly seen when there is an obstruction. So once bilirubin which gets conjugated in liver, it is excreted in bile. Now this bilirubin which is excreted, the bacteria which are present in gut metabolize this conjugated bilirubin and produce urobilinogen and stercobilinogen. Urobilinogen is partly reabsorbed in enterohepatic circulation, and finally it is excreted as urobilin in urine. Similarly, stercobilinogen is also excreted in feces as stercobilin. Now, whenever there is obstruction, stercobilin is not formed in the GIT. Because of obstruction, the bile which does not enter into the gut, and these bacteria which are present cannot act, and hence the stercobilinogen is not excreted in obstructive jaundice, and patient will have pale colored feces, which is characteristic of obstructive jaundice. Now, to have clinical jaundice, bilirubin must rise more than 2.5 milligrams. So it is very important. The early rise, we will not have any clinical jaundice presentation. Now, it is less markedly increased in hepatocellular jaundice than neoplastic obstruction or intrahepatic. So obstructive hepatobiliary diseases will have much more rise of conjugated bilirubin than hepatocellular jaundice. Viral hepatitis, higher bilirubin suggests more liver damage and longer clinical course. Also, in alcoholic hepatitis, if bilirubin is more than 5 milligram, which indicates generally a poor prognosis. So bilirubin is one of the important factor, and even the categorization of bilirubin, whether it's conjugated or unconjugated, also help us to differentiate type of liver disease. Now, there are certain enzymes which we said like SGOT and SGPT, that is serum glutamate oxaloacetate transaminase and serum glutamate pyruvate transaminase, which are very routinely done. So it is so important to know as how this test can differentiate hepatocellular injury. Now, both these are sensitive markers for hepatocellular damage. Livers are directly related with extent of cellular damage or injury. Now, levels which are more than 4,000 generally indicates toxic injury, especially like acetaminophen, drug toxicity, which gives very high SGPT and SGOT levels. These levels we generally don't see in hepatocellular injury. Then also SGOT or AST is also present in heart, liver, skeletal muscle, but it is present in low concentration in kidney, pancreas, and RBCs. When there is a liver cell damage, SGOT rises, starts elevating at 8 hours after cellular injury, which peaks at 24 to 36 hours and returns to normal within 3 to 7 days. Levels of AST remains always high in patients with chronic hepatocellular disease. Then whenever there is extrahepatic obstruction, like with gallstones, AST levels quickly rise. So rise in extrahepatic obstruction, the AST and ALT rise is very high, but they come down very fast also. So this is very characteristic of extrahepatic obstruction, rise of AST, maybe more than 10 times, but which comes down within 1 or 2 days back to the normal. In cirrhotic patient, levels of AST depends on amount of active inflammation. So cirrhotic, of course, there is inflammatory phase and resting phase. So based on active inflammation, AST rise will be high or maintained. Similar to AST, ALT or HGPT also elevates after 8 hours, peaks at 24 to 36. So both these enzymes, when in liver disease, go side by side, except in alcoholic hepatitis, where AST rise is more than ALT rise. In acute viral hepatitis, ALT-AST ratio is usually more than 1. So ALT or HGPT rise is much more than HGOT in viral hepatitis. In most hepatocellular disease, other than viral hepatitis, ALT to AST ratio is usually less than 1. So hepatocellular, viral hepatitis and other hepatocellular diseases, the ALT-AST ratio is different. AST is also released more than ALT in chronic hepatocellular disease. So cirrhosis, generally we see AST higher than ALT in hepatocellular chronic diseases. Also, AST can be increased in myocardial infarction or muscle diseases, but ALT will be always normal because AST is present also in heart muscles and skeletal muscle, but ALT is quite specific for liver disease compared to HGOT or AST. Now, what is the significance of alkaline phosphatase? Now, alkaline phosphatase is present in much higher in liver, biliary tract epithelium, bone, and placenta. Now, this alkaline phosphatase in liver, it is present in Kupffer cells of biliary collecting system. It is increased in both in liver as well as bone diseases. In liver disease, the increase is due to synthesis by cells lining bile canaliculi in response to intra or extrahepatic. So alkaline phosphatase will not differentiate whether the obstruction is in intrahepatic or extrahepatic obstruction. ALP values greatly increase in both intra and extrahepatic biliary obstruction as well as in cirrhosis. Smaller elevations of ALP or alkaline phosphatase are seen in hepatic tumors, hepatotoxic drugs, and hepatitis. Now we must know, besides liver, ALP is also present in other organs, especially bone. Bone is the other common extrahepatic source of alkaline phosphatase. So in children, especially when they are growing, we always say the normal range also in children is much higher than adult levels. Then in healing fractures where the alkaline phosphatase is on higher side, and conditions involving bones like rheumatoid arthritis and hyperparathyroidism will have high alkaline phosphatase activity. Then another extrahepatic source is placenta. Generally in third trimester, alkaline phosphatase, maternal alkaline or placental alkaline phosphatase appears in blood during pregnancy. Also, other sources are small intestine and kidneys to smaller extent. But bone, placenta, and liver are the major source of alkaline phosphatase. Now, that's why it is very essential to know difference between bone alkaline phosphatase and liver alkaline phosphatase. These are the two major isoenzymes of alkaline phosphatase 1 and alkaline phosphatase 2. One is produced by liver, which is heat stable, and alkaline phosphatase 2 is produced by bone. Now they can be differentiated by doing isoenzyme electrophoresis, because biochemically there are no tests available where we can do bone alkaline phosphatase and liver alkaline phosphatase. But electrophoresis definitely separates these two alkaline phosphatase. And alkaline phosphatase 1 is specific for liver disease. Then gamma glutamyl transpeptidase, which is another enzyme which catalyzes transfer of amino acids and peptides across membrane and involved in glutathione metabolism. Now it is present in very high concentration in liver cells and biliary tract. Also at lower levels, it is present in kidney, spleen, heart, brain, and prostate. The values are much higher in males, mainly because of alkaline phosphatase. Prostate is another source of alkaline phosphatase. So in males, the GGTP levels are higher than females. It's a most sensitive indicator for detecting biliary obstruction, cholangitis, and cholecystitis. Elevation of GGTP parallels that of alkaline phosphatase in liver disease. So whenever there is biliary obstruction, both alkaline phosphatase and GGTP will rise. But GGTP is quite specific for liver, but alkaline phosphatase can rise in other conditions involving bone, if there are simultaneous bone diseases are present. Now, it is important to know normal GGTP with elevated ALP levels may indicate skeletal. As I said, that bone is another source of gamma GT. The elevated, but in bone diseases, alkaline phosphatase levels will be very high compared to normal GGTP levels. Elevated levels of GGTP with elevated ALP indicates hepatobiliary. So if both are high, generally it indicates hepatobiliary disease. And GGTP is not increased in bone disease or childhood or pregnancy. I have already said that these are the other sources of alkaline phosphatase. GGTP is also useful in screening and evaluation of alcoholics. Levels are elevated in about 75% of patients who are chronic alcoholic. So this GGTP test is also used in evaluation of alcoholic patients. Then the synthetic function of liver is judged by detecting albumin and globulin. They are the most of the proteins present in blood. Albumin helps in transportation of important blood constituents such as drugs, hormones, enzymes. Globulins is a key component of antibodies, glycoproteins, lipoproteins, clotting factors, complement proteins, and acute phase reactants. See, globulin are divided into three: alpha, beta, and gamma. The alpha and beta globulins are produced mainly in liver, while gamma globulins are mainly produced by reticuloendothelial system. Of course, there are certain beta and alpha gamma globulins, especially which are involved in clotting factors and complement proteins, are produced within liver cells. Albumin is the major protein synthesized in liver, thus used to assess hepatic function. The half-life of albumin is 12 to 18 days. The severe impairment of hepatic albumin synthesis may not be recognized for several weeks. So albumin has a longer half-life. So unless there is a liver disorder for longer period, the albumin will not decrease in blood. So it takes time for albumin to decrease whenever there is a hepatic disease. Hypoalbuminemia is a feature of advanced chronic liver disease and severe acute liver injury. Now, this table will give us a general idea about utilizing these various tests and differentiating or categorizing hepatic disease. So as I said, hepatic diseases are classified into prehepatic or hemolytic, hepatic, and cholestatic or obstructive or post-hepatic disorders. Now in hemolytic, the unconjugated bilirubin will be very high, conjugated bilirubin will be normal, and urine urobilinogen will be high. Of course, AST enzymes will be normal because the rise of bilirubin is mainly because of hemolysis and not liver damage. As against this, in hepatic, the enzymes will rise along with conjugated bilirubin. So in hepatic, both conjugated and unconjugated bilirubin will be on higher side, along with increase in AST and ALT. And of course, since there is no early hepatic disease, there is no obstruction, so ALP and GGT may be normal. As against this, in cholestatic jaundice, it is the conjugated bilirubin which dominates, and since there is an obstruction to the bile flow, the biliary tract produces excess amount of ALP or alkaline phosphatase and gamma GT in cholestatic or obstructive jaundice. So this table gives a good overview of categorizing different hepatic diseases based on liver biochemical test. Now, this is another very important test in long-standing or chronic liver disease, prothrombin time, because prothrombin is also produced within liver along with other coagulation factors. Prothrombin time is a measure of activities of certain coagulation factors made by liver. It is useful indicator of hepatic synthetic function, and increasing prothrombin time may be earliest indicator of hepatocellular damage. So of course, prothrombin time is commonly used along with other liver function biochemical tests. Prolonged due to lack of vitamin K absorption in obstruction. In obstructive jaundice, prothrombin time is high mainly because of there is no absorption of vitamin K. And once we give vitamin K in such patients, the prothrombin time comes back to the normal. So prolonged due to lack of vitamin K in obstruction or lack of synthesis in hepatocellular disease. So we can differentiate it by giving vitamin K in such patients, whether it's a due to hepatocellular disease or due to the obstruction. If there is a correction within 24 to 48 hours in obstruction, will be in obstructive jaundice, but not in hepatocellular disease. Because in hepatocellular, obviously, the prothrombin is not produced by the liver. Failure to correct suggests poor prognosis. That means there is an extensive necrosis of liver cells. Marked increase is a good indicator of severe liver damage in hepatitis and cirrhosis. Now, there are other tests which are done in certain specific liver diseases like alpha-fetoprotein, which is a very good marker for hepatocellular carcinoma. Then ceruloplasmin, which is decreased in Wilson's disease, where there is a disorder which is associated with copper metabolism, and copper is accumulated within liver cells. Then in specific cases like cirrhosis or biliary obstruction, or even in multiple myeloma, there is a derangement in the protein and albumin ratio. Serum protein electrophoresis is very helpful. In cirrhosis, albumin is decreased, gamma globulins are increased. Now, these gamma globulins not increased will be a diffuse form, not like a sharp spike which we see in myeloma. So this is in cirrhosis, the gamma globulins are raised. In biliary obstruction, both alpha-2 and beta-2 globulins are increased. Now, to summarize this test, liver function test and associated abnormalities. Generally, the enzymes SGOT, SGPT or ALT, AST indicate hepatocellular damage. Bilirubin pinpoints if there is a cholestasis, impaired conjugation, or if there is a post-hepatic biliary obstruction. Alkaline phosphatase, also cholestasis, infiltrative, if there is infiltrative disease or biliary obstruction, the values will be very high. Prothrombin time and albumin pinpoints if there is a defect in the synthetic function of liver. And gamma GT and 5-nucleotidase are similar to similarly indicate biliary obstruction in liver disease. Thank you.
Thank you, Dr. Shingnapukar. It was a very nice information about the liver function test. Now there is one question from the panel, from the audience.
Yes, madam.
In a routine examination, if SGOT and SGPT are slightly increased, highlighted in the report, do we have to consider that?
See, generally in practical purpose, as long as SGOT, SGPT are below 100, even though normal range is up to 40, till 100, generally we don't expect physicians to take any action, because they can be raised by various factors. Even drugs can increase slightly HGOT, HGPT, drug metabolism. So many times these patients are on drugs and you have mild increase of HGOT. I think generally they are ignored. But if there is a rising trend, definitely we have to look into it.
And one more question. In NAFLD, how long it takes for liver enzyme to return to normal?
No, very difficult question actually. How this disease will respond to line of treatment is very difficult to predict. And enzymes are generally rise, but they are again at milder levels. So very difficult to predict when they will come back to normal. Because the response itself is varied with patients in different patients.
Any more question from the panel?
I have one quick question, if I may.
Yes.
Yes, please.
Yeah. So, is there a way to differentiate from the LFTs a difference between alcoholic-related liver disease or alcoholic cirrhosis versus non-alcoholic through LFTs?
No. If it is cirrhosis, no. If it is alcoholic, definitely GGTP is one parameter which is generally raised with alcohol intake. But in chronic, once it goes into cirrhosis, I don't think we can differentiate alcoholic cirrhosis from other. Not based on LFT, routine LFT biochemistry test.
This is
Thank
the
you.
end of the session. Thank you so much, Dr. Shingnapukar, for giving
Thank
a
you, madam.
wonderful,
Thank you.
excellent information. Thank you so much once again. Now I request Assistant Secretary, IMA CGP Sub-Faculty, Mumbai branch, Dr. Kajal Ahuja, to give a vote of thanks. Over to Kajal Ahuja.
Good afternoon, all. I would like to thank our speakers of today's webinar, namely Dr. Akash Shukla, Dr. Sevanti Limaye, Dr. Shrikant Atloori, and Dr. Surendra Shingnapukar. I also thank our knowledge partners for the day, Sir H.N. Reliance Hospital. I thank Mr. Deepen Mehta, Mr. Piyush Kale, and Ms. Vaishali Tanpure from DigiShale, who have given us the platform for this webinar and handled all the technical details at the same time. I thank Dr. Anil Awad, President-elect of IMA Mumbai branch, and Dr. Usha Shah, Assistant Director, IMA CGP, for conducting this webinar smoothly and efficiently. A big thank you to our managing committee member, Dr. Sachin Patharkar, for being the MMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much.
Thank you, everybody.
Thank you. Bye.
Bye.
Thank you. Thank you very much. Thank you very much. Thank you very much.